activity. As you know, inflammation are an ongoing status, and we can detect it by MRI. So this is the reason why we are performing regularly MRI in patients under disease-modifying treatments. If there's an unexpected clinical attack or evaluation of diagnosis, we should perform MRI. And routine spinal cord MRI and the follow-up is not necessary unless there's a clinical presentation of transverse myelitis. So let's turn back the case. Increase in lesion load over time. Admission to our center at February 2019 with sequelae complaints and also additional T2 lesion, and the EDSS was 2.5. You're seeing the increase of lesions over time. And a year later, she told us her pregnancy planning, and I talked about the patient, and then I mentioned the rebound activity after fingolimab discontinuation, and then the patient decided not to get pregnant because of the risk of the rebound activity. But after 5 months, then she came to our center, and then she mentioned us, "Okay, I'm ready for the pregnancy, and we can discontinue the drug." And then I talked to the patient about the risks because there was no any pregnancy before the disease, so we both decided to discontinue the drug. At the time of the discontinuation of the drug, lymphocyte count was 600. 3 months later, she was doing well, but at March 2020, she was presented with weakness in right lower extremity, numbness in both lower extremities, and EDSS was 3.5. We gave the patient ivermectin prednisone for 10 days, and we obtained partial improvement. At the time, we didn't perform MRI because she was not sure about the pregnancy, and then just because we were sure of the relapse, and then the patient, the other reason for not performing MRI, the patient did not want to have MRI, and just requested the treatment, and we gave ivermectin prednisone. But after 2 months, she was presented with a new relapse, and at that time, the EDSS of the patient was 7. We hospitalized the patient, and these are the MRI of the patient. Lots of lesions, tumor-factive lesions, brainstem lesions, and lots of contrast. Lots of lesions having contrast on the left side of the temporal area, on the brainstem, and also at the level of C3 to C4. So, and then again, we treat the patient with ivermectin prednisone, and after plasma exchange, we obtained partial improvement, and then we started alemtuzumab this patient as severe activity and lots of contrast enhancing lesion. Also, we might consider ocrelizumab or cladribine in these patients. Good afternoon to everyone from Turkey. First of all, I would like to thank
So I think talk is over. Any questions?
Thank you, Professor Ugur, for your talk. I have a question. What's the dose of methylprednisolone that you use for 10 that you give for 10 days?
1 gram every day, 10 gram in 10 days, it corresponds to. But in some cases, in mild, let me say, in mild relapses, we tend to use 3 to 5 days. But in the severe relapses, which presents with pyramidal system signs and with higher EDSS, we tend to use 7 to 10 days, 1 gram per day.
Okay, hi Ugur, this is Dr. Wasay. Good to see you. How is everything in Istanbul?
Good, everything is going well.
Now, how strictly you are following this 6 months dosing in ocrelizumab? Why I'm asking, because I have 3 or 4 patients, and in those we kind of extended the dose, so we have given like 8 months dose. So we gave like 3 doses in 2 months. So far they have done very well. So my question is that how is your experience regarding this this increased dosing? It's very important because Here, patient has to pay out of pocket. So 4 doses in 2 years versus 3 doses in 2 years makes a whole lot difference. So what are your thoughts on?
So let me start with our center experience because we have around 700 patients receiving Ocrevus. We have learned a lot of things during the pandemic about Ocrevus as well. Because of the severity of the infection, particularly in cases having high EDSS and the older age, we discontinued the Ocrevus for a while and then extended the duration of the doses. In these patients, they received Ocrevus in 9 months, or maybe in some of the patients received every year during the pandemic. And this is only my experience and our center experience. We did not observe any clinical or radiological activity, even we extended the doses to 1 year in some patients. And beside that, recently, due to regulations in Turkey, we did not have a chance to get Ocrevus for 3 months. And in our center, we decided to extend the doses to 8 months in these patients. And none of them also had any clinical or radiological activity. So we are following the CD19 and CD20 levels in these patients. In some cases, if the CD19 and CD20 gets lower in the lower levels, around 0, 1, maybe we can extend the dose to 8 months or 9 months. But on the long term, we don't have any experience because we are just using the Ocrevus for 5 years. But I believe that it's a kind of an induction treatment in multiple sclerosis. On the long term, we can extend the dose to, and then maybe some patients in the later ages switch the treatments of Ocrevus to other drugs, or maybe we can discontinue the drug after 10 years. But this is kind of my view. So if you remember the cyclophosphamide in multiple sclerosis field 15 years ago, this kind of induction and suppression therapy, most of the patients who have received cyclophosphamide and then switch to first-line drug after a while, they do not have any clinical or radiological activity on the long-term follow-up.
Okay. Sarmad has it.
Hello, Ugur. I'm Dr. Sarmad. I would like to ask how frequent you do CD20 and CD19 prior to the next dose of ocrelizumab, or you really do it now, or initially in rituximab there was a study in which they, before giving the next dose of rituximab, they used to do the CD19 and 20. What's your take on it?
So we have experiences coming from NMO spectrum disorder while the patients have on rituximab treatment. We were checking every 6 months, CD19 and CD20, while the patients have receiving rituximab for NMO spectrum disorder. Why we have checked these cases? Because we were trying to extend the dose of rituximab in NMO spectrum disorder, but we did not find, and also the papers which was published regarding the extension of rituximab in NMO did not find any significant correlation between the extension of the rituximab and CD19 or and CD20 levels. Actually, we don't regularly check in MS while the patients receiving Ocrevus, but if we cannot have access to Ocrevus, and I mean, if we have to extend the dose because of the availability issues of the drug, then we are checking CD19 and CD20, and then we are explaining to patients that, okay, these are your tests, and probably the drug is still effective, and then we can extend the dose because the drug was not available for a while in Turkey. But regularly in Turkey, we don't check CD19 or CD20 when the patients are on Ocrevus treatment, particularly in the MS.
Thank you, Ugur.
My question is, when will you consider stopping disease-modifying therapy in primary progressive MS?
So this is a controversial topic in multiple sclerosis. So, you know, from the natural history studies that progression starts at around age 45. And if you look at the chart, even it doesn't matter primary or secondary progressive. The age interconnects at age 45. And then the immunosenescence, the concept of immunosenescence, especially after at age 55. If the patient and then progression slows after at age 55, but if you look at the radiological studies, the most important one, smoldering lesions, there are also, if you don't, even if you don't detect any radiological activity by classical MRI investigations, there's still ongoing inflammation, which was shown by smoldering lesions and also paramagnetical rims. So this means that there's, even after at age 55 or at age 60, there is still ongoing inflammation. This is the evidence-based part. So based on these studies, some of the physicians suggest not to stop the drug even at the later age. But if you look at the other natural history studies and our experiences, we know that the clinical clinical relapse activity and radiological activity decreases after at age 55. We are giving the decision for stopping the drug individualized, looking at the age and considering the premorbid MS clinical history. If the patient is stable more than 15 years, and if the patient is around at age 55 or 60, and if there is no radiological activity in patients, then we talk with the patient, and then we may give a chance to stop the drug after at age 55 by personalized. This is the important thing, because we know that if relapses happen around this age, at age 50, 55, it tends to occur very severe. And the most clinical presentation of relapses at these ages are myelopathy. So we should be careful when giving a decision of stopping the drug in multiple sclerosis patients. The second issue is that some of the patients are still on interferon treatments. So we know that interferons increase the spasticity of the patient and the walking impairment in these patients. In these patients, we are stopping interferons, and then we observe that spasticity decreased after stopping interferons, and also fatigue got better after stopping interferons after at age 55 in patients without clinical and radiological activity.
So, Dr. Ugur, I have the same question about relapsing and limiting multiple sclerosis patient. So the patients who are on ocrelizumab, you have presented 7 years safety data on ocrelizumab. So the patients of RRMS who are on ocrelizumab and the disease has been fairly stable, like no radiological lesions, no clinical relapses, when will you stop it? So in our country, the Ocrevus has been there for the past 3.5 years, but after 3 years, really the patients, they cannot afford or cannot continue to pay for this medication. So will you stop it altogether, or will you switch to some mild MS medication like interferon in RRMS patients?
So it's hard to give evidence-based response to question. It's a good question, but meantime, we don't have experience and we don't have evidence stop Ocrevus after 3 years or 5 years. We should treat the patient with Ocrevus or with other drugs as long as it's possible. But I was just talking about the extension of the time from 6 months to 8 months, or in some places in 9 months. But discontinuation is a very hard decision in these patients. But if you cannot have a chance to get Ocrevus or other drugs after 3 years, I prefer to start not the first line drugs such as interferons, because the efficacy of them is 33%. And the patient is probably the patients that were receiving ocrelizumab were younger, and then when you consider the progression age at around 45, they deserve to get effective treatments at these ages. So if you have a chance to cladribine or dimethyl fumarate instead of interferons, I would suggest to start them in case of you cannot have a chance to give Ocrevus.
Thank you, Dr. Ugur. So here I'll conclude the session. This session was consistent of 2 international speakers. Number 1 was Dr. Rumaiza Al Hussein. She was from Saudi Arabia. She nicely talked about the diagnostic tools of MS, especially McDonald's and Magning's criteria. And she talked about the evolution of the criteria over the years. And then she described the morphology of MS lesions and how to differentiate from the mimickers. And then she, at the end in the question answer session, described some of the treatment perspectives also, especially in the pregnant and the ladies who are with the lactation. The second speaker was Professor Ugur. He was from Turkey. Talked about the advancement in the MS treatments. He nicely described about the progression of the disease and how to evaluate the progression. There are certain criteria like Rio criteria and how to escalate the therapy according to the progression. Especially NIDA-4, NIDA-5 can help us while considering the progression of the disease and escalating the therapy. So at the end, I would like to thank the sponsors, Roche, for the arranging this all session. And now we'll proceed towards the next session. Over to. Thank you, God. See you soon.
Thank you, Dr. Rumaiza and Professor Ugur, for sparing your precious time and sharing your knowledge with us. And we will now proceed to our 4th session. This session is sponsored by Sanofi Genzyme. And this session will be chaired by Dr. Haris Majid Rajput, who is a consultant neurologist from PIMS Islamabad with vast experience in demyelinating diseases. This session will also be chaired by Dr. Ghulam Shabir. He is a consultant neurologist practicing in Faisalabad. And Dr. Irfan Khatak, who is a consultant neurologist in Khyber Teaching Hospital, Peshawar.
So for the first talk, we'll be inviting Professor Dr. Pascal Rufi to discuss journey of Aubagio. Kindly start with the first talk.
So thank you very much for the kind invitation, and it's a pleasure and honor to be part of this meeting again for the second Paktrims conference as it was last year. So I really appreciate to be with all of you. And my presentation will be dedicated over the next 20 minutes on Aubagio. So let me just share my screen. Hope you can all see my screen. as an introduction, I would say that it's a pleasure to say that now 10 years after the launch of this product, many, I think, patients are benefiting worldwide from this small molecule. As a company, as you know, at Sanofi, we are committed to develop new products, new DMTs in this field. And I hope that in the next future, really next year, we can present also new data on our BTKI product that is currently in development in phase 3, and also other DMTs that we are developing in MS. But for the time being today, I will give you just an overview of where we are 10 years after the launch in Europe and worldwide of teriflunomide. So I am Sanofi one of the Sanofi medical directors, and really developing MS product and also part of the medical affairs team. So we have seen this morning that it's very important for you as physician, neurologist, MS specialist, and also for the patient to address the unmet need of MS. And you know that I will focus mainly on what is important for the patient. You know that disability is one of the major unmet needs in MS, and this is why we need still product in the progressive phase to be developed. We know that also patient-reported outcomes and quality of life are important for a patient, and we have seen also this morning that MRI component is key in MS, and we have new MRI techniques or new measures coming recently, you know, that are really looking more in depth into what we call the smoldering component of MS. So going beyond relapses, looking about, you know, definitely also the smoldering component, smoldering disease. We also know that adherence is key in this field, and we need to have those patients taking the drug over the long time, and to make sure we know that many patients also are switching from one DMT to other DMTs, and we need to also have some data on switching therapies. So we all know that we had the phase 3 program in MS for Aubagio, showing the effect on relapses versus placebo. You all remember the TEMZO trial. What we have now is the long-term follow-up in what we call the extension studies, showing that 9 years after the launch of after the extension study, you can see that 9 years after, we have consistency effect on the relapses, so low relapses rate up to 9 years of treatment for those patients who moved into extension phase. So this is really showing that relapses is one component that Aubagio can address, and you know that relapses are important in MS, because this is what the regulators are asking us to prove when we are developing those drugs, so effect on relapses. We also know that in the real world setting, this is a study that was shown developed in Germany called Taurus study. In the real world study, you can see that for patients shifting from previous DMTs to Aubagio, you have after 2 years a drop in the relapses from 0.87 to 0.35. So mainly showing that the relapses decrease over time in this real world study that was conducted in the large population scale in Germany, over 1,000 patients in many centers. So the majority of those patients here were taking higher DMTs, and it's nice to see that when they shift to Aubagio, there was a drop in the annualized relapse rate. In terms of numbers, you remember also probably that Aubagio was there were two pivotal studies, Tower and TEMZO. In the two studies, there was a consistent effect in terms of effect on disability of Aubagio. So these two studies were showing a decrease in terms of EDSS and strong effect on disability progression. You can see that 80 to 84% in the two studies of the patients remain free disability progression over 2 years of treatment. And this was quite remarkable, because this is probably showing that this product has an effect on top of the classical effect on T and B cells, probably having an effect on CNS resident cells. Over the long term, you can see that in terms of, for example, over 9 years, 7 plus 2 years of treatment, EDSS scores remain quite stable over time. That means that effect on EDSS having an effect on disability over the long time period with Aubagio is something important as well to know that EDSS is quite stable over time. What we have shown as well with Aubagio is an effect on brain volume loss. Again, this morning we have seen in one prior presentation the effect on brain volume loss is very important for MS patients. Why? Because we know there is a correlation or a significant effect of brain volume loss and cognition parameters, for example. And here you have the study that has been conducted in Switzerland using the Siena method in Basel, showing that after 1 year or after 2 years of treatment with teriflunomide, you had a 36.9% reduction versus placebo. And this was also confirmed statistically significant also after 2 years of treatment with a decrease of 30.6% reduction on brain volume loss versus placebo with the treatment. So I think that is very important, showing that the reduction on brain volume loss using Siena method was statistically significant. And I will show you also that this was correlated with an effect on cognition parameters. And this was shown here by Professor Steiner in Germany. What we call PTE is mainly the proportion of treatment effect that could be explained by the independently by the product. So I think you can see that here Aubagio was associated with significant reduction in terms of disability worsening, and mainly explained by the effect on brain volume loss. So brain volume loss accounted definitely for the large proportion of the effect on disability worsening. So impacting brain volume loss is definitely something is very important for Aubagio to translate into an effect on disability. And this was also shown in the same study by Professor Steiner, that also the effect on brain volume loss accounted also for the positive effect on cognition performance and on cognition outcome measures. So we have also seen in the randomized control trial that using the PASAT score, using Z-score from the PASAT, we had a significant reduction and improvement into cognition in the randomized control trial, and this could be translated also into the long-term study. What we have seen also that in patients switching from Aubagio to Aubagio from prior DMTs, including platform therapies and also including high efficacy treatment sometimes, we can see that in the Taurus study, for example, in large cohort studies in Germany, most of the patients improve treatment satisfaction. You can use here the TSQM scoring system. So TSQM, you see that higher the score, better it is for the patient. So as measured by the patient, there was an improvement in convenience, global satisfaction, or effectiveness in patients switching from prior DMTs. So the majority of those patients received DMTs. You had also some naive patients as well, but you can see that for the patient, treatment satisfaction was improved after 2 years of treatment when you had the assessment of TSQM into the larger database. We had also a very large phase 4 study called TeriPro. In this TeriPro study that was published by Professor Cole in the US and Professor Patrick Vermerge in France, you can see there was in patients switching from prior DMTs as well to Aubagio, there was an increase after 48 weeks of treatment, a statistical significant increase in terms of effectiveness, global satisfaction, and also convenience and side effects for those patients who switch from prior disease-modifying therapies to Aubagio. So this is very important information to consider, because for patients switching to different products, it's important to see if they increase, of course, their satisfaction to the treatment in terms of efficacy, effectiveness, in this case, or safety. This is also when it comes to cognition parameters, we use the SDMT and also MSPS. I think tools in the TerryPro SAM trial, and you can see that the mean score for the SDMT mainly remains stable after 48 weeks of treatment, and it's important for this patient to see that cognition parameters are remaining stable under treatment over a long period, probably showing that what I discussed before, the effect on brain motor loss translated to effect on cognition outcome measure in a positive way. And this is also what you can see here. After almost many years of treatment, up to week 96, there was an increase in the PASAT-3 scores, significantly improved with Aubagio. That means that for this patient taking Aubagio, you can have some improvement or stability depending on the kind of study in terms of cognition and cognition parameters. What is important to know for this product that now we have a large database and real-world database showing that there is a consistency in terms of safety. Mainly what we know for this product, you have a GI effects, you means nausea, diarrhea. You have also, in some cases, some hair thinning, and also we had also some, very rarely, some headache. And what you have also in the label, LAT increase. So this is why you have a monitoring plan in place for this product, like for any DMTs, but mainly you have to do some blood samples to check, of course, the lab parameters, including LAT values. And also, you know that, of course, you have to follow your patient and to monitor also other lab parameters. As you know, usually you have a lymphocyte reduction of 50% with this product, which is still in the range of what you can see for lymphocyte counts or neutrophils, which is quite minor. But of course, you have to also check those counts. Well, overall, we have a safety profile that didn't change really over the 10 years post-launch. And this is quite also something important for any DMTs that you have, because during the first years of treatment, you need to make sure that the safety profile of this product is not changing completely. But of course, what we have for Aubagio, you have quite stability in terms of the risk. So as you know, for any DMT, the risk is not static, but for Aubagio, we haven't seen new emerging safety events, and especially new PML case has been mentioned. So this is also important for this product. As you know, PML is something that we need to look at. And for Aubagio, I think probably because of the immunomodulatory component of this product, we don't have any really reported confirmed PML case at this stage after 10 years post-launch. What is important to see that according to different group of age, no differences really in terms of safety profile. In large databases that were conducted here, you can see in France, it's important to see the persistence versus other DMTs. For example, there's also a large cohort in France from the offset database or the SNIRAM database. You can see that, for example, versus injectables or dimethyl fumarate, Aubagio was, in terms of persistence, doing a little bit better over time. That means that the patients stay onto the drug really in a good way. So that means it's important to see that the patient is taking the product over the long run into large databases. So I think it's good to have real adherence that is proven into large cohorts. We have seen this also in another cohort, for example, in Italy, in terms of discontinuation rates. You can see, for example, here in this study that discontinuation rate of teriflunomide was occurring in a lower percentage versus dimethyl fumarate. Now, of course, we have still a lot of publication, and I just selected few papers for the aim of the presentation today, but many studies are still running in worldwide. You know, there are a lot of real worldwide data now that have been published over the last years or so in large cohort of databases. You know, we are using all the existing databases to do some cross comparison studies for Aubagio, and voila, you can of course see all those publications now coming in large papers and of course peer review journals. I think this was a really extensive development program that we had for Aubagio. For the new compound, you will probably see even more larger studies, because if we take our product currently in development, BTK, so BTK inhibitors, we have even more large cohorts now. That means the regulators or health authorities are asking us to prove much more new parameters, new outcome measures that it was the case before. And I think for teriflunomide, in that case, I think this development program was really huge, and I think we still continue trying to develop some new studies to continue to assess the benefit risk profile of this product even 10 years after the market, which is quite remarkable. In terms of pregnancy, this was also something that was discussed during one of the previous presentations. As you know, we had a large presentation and a recent presentation and publication from Professor Rufi in France, and also during the EAN Congress in 2022. Many patients, there is a strict contraindication for this product during pregnancy in pregnant women, because of potential teratogenic risk that was identified in animal models. But what is important to see here, that in large cohorts, that even some patients, some women became pregnant during the phase 3 program, or even in the real world setting. And it's important to see in those patients, in those young women that had babies during their and taking teriflunomide, which they shouldn't. It's important for us to see that there were no differences in terms of reproductive potential, or even no, the rate of spontaneous abortion was exactly the same that what we could see in the normal population. So there was no new identified risk in terms of or pattern in terms of malformation. So this is very reassuring data. And this is also what we have seen 20 past years with the parent compound leflunomide. So no signal in human has been really detected, and no rate of specific malformation, but definitely this product should not be prescribed in young women of able to have some babies. And also, that there is a rapid elimination procedure that is available for this product that can eliminate the product after 11 days of cholestyramine or activated charcoal that could be taken in necessity. We also know that vaccination is very important. We are still in this COVID-19 pandemic, unfortunately, in many countries, as you know, worldwide. And we have presented a lot of data about vaccination studies for teriflunomide. So you see, for example, the human response after, for example, Pfizer vaccine here. This was a study presented by Professor Sormani in Italy. And you can see it's very important to see the response rate and the level of antibody titers in the blood was very effective. So it means you can mount effectively and protectively for the patient taking teriflunomide, and this was done in a prospective way, in a positive way. I think that means the IgG level was really effectively mounted, antibody titers in the blood. So I think it is very important to see that for the patient taking teriflunomide, they will be protected, and you can still continue to take this product, of course, during this pandemic. And this was also, so we are also when it comes to flu vaccine, this was also the same. You see that now taking this product, you can see that you can have also a level of protection that is effective immune response to seasonal influenza vaccinations. I think we are in a season where you have a lot of patients who are hit by the virus, especially, for example, in France at the moment, many patients are hit by the COVID pandemic and also by flu. And it's important to see that those patients could be protected definitely if they are still continuing to take teriflunomide. So as a conclusion, I would say that we have now 10 years after the market, a long-term benefit of this product on the key parameters of disease progression, MRI outcome measures, including brain volume. We have seen that cognitive performance is quite going in a good way for this product. We have seen also that for the patient, in terms of effectiveness and also, treatment satisfaction, this was also something that was really satisfactory in many trials. We have reassuring data in terms of tolerance and persistence, or I think even in terms of safety profile of this product over the long run. We are continuing to look about this product, of course, because this is a product that is now prescribed in many countries for many populations, even switching patients switching from prior DMT and in naive patients. We are continuing to also elaborate a little bit more about potential additional benefit about this product. We just published, it was accepted for publication last week, some effect in vitro on SARS-CoV-2. So we think also that this product has an effect on EBV and on SARS-CoV-2. So having a kind of antiviral effect of this product, which could also benefit, especially for the patient, mechanistically speaking. And also we are looking about effect on this product on other new MRI parameters, including probably what we call chronic active lesions in the brain. This product is also going into, even in a small percentage, in also crossing the blood-brain barrier. So we are also looking potentially about benefit of this product on CNS resident cells. But as a conclusion, I think I would say that we had this product that we launched 10 years ago. At the same time of alemtuzumab, Lemtrada, with two products now on the market, but we are looking definitely in the future for having also new options for you as physician neurologists with BTK product, but we are waiting the phase 3 results, and also for other DMTs that we are developing in our company for MS, because we really think that MS, there is an unmet need in progressive patients, and we need to continue to have effective products like Aubagio and even more effective products probably in the future with new generation of DMTs. I thank you for your attention. I think if there is a time for questions, I know it was a kind of helicopter view, but this is some of the papers that I selected for the purpose of this conference today. Thanks again.
Thank you, Dr. Pascal, for a very comprehensive review. My question is regarding the role of teriflunomide in the current DMT landscape, where there is a paradigm shift from the escalation to induction treatment modalities. So what comments regarding that?
Yes, no, that's I think it's a critical question. In fact, that we are using this product, I would say, definitely as first line, and also as I said, this product is really used also in patients switching from prior DMTs, especially I would say switching from prior DMTs like injectables or Copaxone, or even from high efficacy DMTs. We had a couple of papers for patients switching, for example, from natalizumab to Aubagio. This was a paper from Professor Edwards in the US for safety purposes. You're right that we can use this product in many occasions. Now, of course, induction versus platform therapies, they have still, I think they're placed in the overall armamentarium of using this kind of product, because we think that this product has a strong effect on disability, as I was showing that. I didn't show today, but you remember probably well the study that was presented, a comparative study of atumumab versus Aubagio, and it's quite striking to see that, for example, there is a strong effect of atumumab, you're right, anti-CD20 therapy on relapses on disability, but sometimes, you know, it's you have some differences really in terms of brain volume loss. So, for example, there is sometimes a disconnect between what we can see with teriflunomide on brain volume loss, even versus high efficacy DMT. But you're right, the shift is definitely recent with anti-CD20 to use anti-CD20 as a first, to hit hard and early. But for Aubagio, I think you can see that what is important for the patient is also the long-term benefit risk profile of this product. This product is very safe, I would say, and quite effective in terms of on disability. So I think this is why this product is used definitely for a large spectrum of patients. And in the future, will tell us, you're right as well, if you will use more high efficacy DMTs first versus platform therapies first. But overall, what I can see that Aubagio is quite used very broadly in large situations. And this is also why we are developing a new, not only Sanofi, but of course Roche and other pharma companies are developing new class of products like the BTKIs. We think that BTKIs can also hopefully address an unmet need, going not only in the periphery, but also hitting the CNS resident cells. And we know that microglia is probably one of the key components, also in the brain. So probably in the future, there is also a place for new agent to go to target the unmet need, and especially not only I would say B cells, T cells, but also what is really going on in the brain for that we think that is the small drawing component. So teriflunomide is I think like BG12 interferons and other DMTs used definitely as a platform therapy, and also for being in different options for patients switching to Aubagio. We have good set of data as well, I would say. But now this product is 10 years on the market, so it's interesting to see how the use of the product has evolved over time, as well by the physician and the neurologist.
Thank you. I think Pascal, a very informative talk, and this is Dr. Wasay. This is very exciting that you have very good data that this medication not only affects the brain volume loss, but also it affects on the disability progression. So this is very exciting. Now I have 3 questions related to use of Aubagio, which we come across. We have a very good number of patients here in Pakistan on this medication. Number 1 is hair loss in young women. We get a good number of young women who are on this medication complain that they're having a hair loss. So how do you deal with that? Like, do you stop the medication or lower the dose, or you do some kind of supplementation? That's question 1. There are 2 more. So the other one is medication dosage, because some patients, they are very stable for 3 years, or no clinical attack or no MRI findings. So we kind of tend to decrease the dose of these medications to like alternate day or 7 milligram. My question is that, is there a data to switch them to leflunomide? Because teriflunomide is available in Pakistan, it's very expensive. Leflunomide is much less expensive. It's available in 20 milligram tablets, which kind of give you about 6-7 milligram of teriflunomide. So is it like, is there any data that we can, if they are very stable for 2-3 years, we can switch them on leflunomide for just a kind of a continuation phase? That's the other thing. And the third thing is that if you want to lower the dose, is it better to give 7 milligram every day, or it's 14 milligram alternate? What would be a better option in terms of giving the medication to these patients?
No, thank you very much for those very important questions. So, I will just say that we developed this product, teriflunomide, which, as you mentioned, is the active metabolite of leflunomide, leflunomide being the parent compound. We developed this product in MS, and we haven't developed leflunomide in multiple sclerosis. So I can only recommend to use teriflunomide in MS because we didn't develop leflunomide in multiple sclerosis. And we know that leflunomide, this was a very strong discussion we had with the EMA some years ago. Leflunomide is completely different because the metabolites that are initiated by leflunomide are different in the blood. So you have different metabolites, and also the hepatic involvement when leflunomide is metabolized is very different to teriflunomide because you don't have all these cytochrome enzyme involvement. So this is why we really think, and this was proven and presented to the EMA, that teriflunomide is safer than leflunomide because you avoid all this hepatic involvement of cytochromes, and also because you are not generating different metabolites that could potentially harm as well. This is why teriflunomide is recommended, and we also recommend the 14 milligram. We don't recommend to decrease the 14 to 7 milligram. We have shown, and this was shown by Professor Comey on the phase 3 program. So when he was summarizing the evidence from the phase 3 program on teriflunomide 14 milligram, it was showing from a safety perspective that 14 milligram is not showing differences really versus 7 milligram. So we really strictly recommend to stick to 14 milligram in terms of usage. We cannot, unfortunately, I cannot recommend to move from teriflunomide to leflunomide because of what I said about the different safety profile. And leflunomide was developed in rheumatoid arthritis, where, as you know, there are concomitant medication, and they are using in rheumatoid arthritis many products at the same time, as compared to, for example, MS, where usually we don't recommend to use combination therapies. We are using one product. This is why I think, to your question, I recommend to stick to 14 milligram because the safety profile is the same as 7 milligram. The only country in the world where we have 7 milligram is the US. Except US, 40 milligram is everywhere else, worldwide. So and in the US now, after 10 years of the market, we can see that for almost 90% of the patient, or even more, 90% of the patient are using 14 milligram and not 7 milligrams anymore. So I think, definitely not using leflunomide in MS because you could potentially have safety issues that you don't have at all for teriflunomide, and we didn't develop leflunomide in MS. We developed teriflunomide, the active metabolite of leflunomide in MS.
How about hair loss?
Hair loss. So this was, thanks again. So the second question of hair loss. So I didn't show this slide, but I remember showing this slide during Paktrims last year. There was 1 or 2 slides last year showing that patient having hair thinning or hair loss can usually continue to take the product, and hair loss is something that usually occurs during the first weeks or first months of treatment and disappear then after. Some physicians are using some, but we cannot recommend. We didn't do any trial on this, but they are using sometimes some preventing strategies that using some vitamins, vitamin B, etc. But overall, we haven't seen so much hair loss overall in the real world studies. When it occurs, usually the physician or the neurologist continue to prescribe the drug, and this is disappearing weeks after. Preventing strategies can only be something that we didn't have any trials to, but I know that sometimes some vitamins cocktails are, I discuss this sometimes with some experts. They are using some vitamins to prescribe that could potentially help. but it's quite rarely seen when I discuss, for example, in France, which is a country I know much better, is we don't have so much hair thinning, to be honest, but I think usually it's disappearing over time. Any other question or?
Thank you, Dr. Pascal, for your comprehensive talk and for the question and answer session. So we'll now move to the presentation.
Thanks to you all. Thank you, Mike, so much.
I'll invite Professor Mohammad Wasay to present his talk regarding cognitive impairment in multiple sclerosis.
Assalamu alaikum, Bismillah ar-Rahman ar-Rahim. So we will be discussing this important item related to full screen. Cognitive impairment in multiple sclerosis. Now, I was in Paktrims this year after a very long time. And every time, in Paktrims, the bottom line for MS is an inflammatory disease. Now, after a very long time, I have seen this shift that people are thinking that MS is not actually an neuroinflammatory disease. It's more of a neurodegenerative disease. There's kind of a change in shift related to multiple sclerosis in the last many years. And this is, I think, an important topic related to multiple sclerosis. This is my disclosures for this presentation and for this conference. In 1887, now we are thinking that MS is a neurodegenerative disease and cognitive problem is a very important issue in MS. In 1887, the first case of MS described by Charcot, actually his emphasis was more on memory and cognition. Like that's what he reported in 1887, that in most of the patients, there's a marked enfeeblement of the memory conceptions are formed slowly. So he noticed like so many years ago that actually cognitive problem is an important problem in multiple sclerosis. Now we are very much hooked on to attacks and motor disability, and we are looking at EDSS. Actually, motor dysfunction is very dramatic and it comes very in a very dramatic way. So that's why most of the attention is paid to the motor symptoms. But actually, cognitive problem is a issue. It's a new, and even if you control the attacks, there is cognitive dysfunction going on in patients, and over a period of time, patients develop and complain of cognitive issues. So this is, I think, what we need to understand and learn, and then we need to pay attention to our patients, because even we are treating their motor symptomatology, we have to also focus on their cognitive issues, because that's what sometimes are making their life miserable. And actually, like in the recent years, about 30 years ago, there was a publication in neurology, and that was Dr. Rao, and he suggested that, cognitive problems are a major problem in multiple sclerosis, and a lot of patients, they have these problems, but sometimes it becomes harder to predict because there are other issues going on with this patient. So he did a cognitive assessment study on his patients, and he reported that overall prevalence of cognitive impairment in MS is about 40 to 70%. So that's a lot of cognitive impairment, which happens in most of the patients. And cognitive is a complex issue. Cognitive dysfunction and cognitive assessment is a complex issue, and maybe not many people understand that what is a neurocognitive domain. So it is like 6 major areas of the function of the brain. So there's a language function, there's a learning and memory, there is social cognition, there is perceptual motor function, there is executive functioning, and there is complex attention. And if you just analyze those domains of the brain function, which is all frontal lobe function, you will realize that how many parts, domains of the brain are affected by these small plaques which are present in the periventricular region or in the brainstem region, but actually they are affecting a whole lot of frontal lobe function by the disconnections and by affecting the whole brain function. So this is, I think, is an important concept which we should know and we should learn and we should understand. And that's what basically, if you look at different domains, this is one of the studies of 100 patients, and it's a case control study. So they have healthy control versus MS patients. And if you look at the domain,